Welcome to our presentation by Medicus of Houston. I'm Dr. Jerry W. Jones, and today I'm going to talk to you about narrow complex tachycardias and AV nodal reentrant tachycardias in particular. I have no disclosures, so let's get started. Here's a very typical narrow complex tachycardia. This was recorded from a 37-year-old female who presented to the ER with a chief complaint of sudden onset of palpitations. From the measurements performed by the ECG machine, we see that the ventricular rate is 185 beats per minute. Remember what I just said, the ventricular rate. By default, what we commonly refer to as the heart rate is really the ventricular rate. But the heart has two rates, the atrial rate and the ventricular rate. Although they're usually the same, they aren't always the same. I use the machine calculations a lot, but you still have to be careful. Sometimes if you have tall R waves and tall T waves, the machine may also count the T waves as R waves and calculate a ventricular rate that's twice what it actually is. For the PR interval, we see only an asterisk. This is because the machine is unable to locate anything that it recognizes as a P wave. It has the same issue when calculating the P-axis in the frontal plane. Now, let's look at the ECG itself. First, note that we're looking at a 12-lead ECG, not just a rhythm strip. This is a very important point. All dysrhythmias, including all tachycardias, are diagnosed from a 12-lead ECG, not a rhythm strip. There are three 10-second rhythm strips at the bottom of this ECG, which are useful, but the 12 leads are absolutely essential in the diagnosis of any dysrhythmia. As for rhythm strips, if I could choose only one lead for a rhythm strip, I would absolutely choose lead V1 first. If I could choose two rhythm strips, I would add lead 2. Now, let's look at the QRS intervals. That's the official term for a QRS complex, but QRS complex is quite acceptable. I say it all the time. So the QRS complexes are all very narrow. The machine says 80 milliseconds, and that's quite plausible. In the His-Purkinje system, as the heart rate goes faster and faster, the QRS complexes will get narrower and narrower. That's physiologic. We expect that, and it's a good thing. The rhythm is very regular. However, I don't see any P waves. If there are any P waves to be seen during an AV nodal reentrant tachycardia, let's just say AVNRT from now on, the P waves are going to be retrograde. That means they will appear inverted in leads 2, 3, and AVF, and upright in lead V1. You probably wouldn't see any retrograde P waves in lead 1 because the P wave vector will be almost perpendicular to the lead 1 axis, making them essentially invisible in lead 1. But you can occasionally see retrograde P waves during an AVNRT, except they won't look anything like what we think of as a P wave. The retrograde P waves, when present, will appear right at the end of the QRS interval, right about the J point. You may see some in the inferior leads, especially in lead 2. They will look like tiny S waves right at the end of the QRS. You may also see a retrograde P wave in lead V1. It will look like a tiny R prime at the end of the QRS. Actually, we call those P waves in lead 2 pseudo S waves, and the P waves in lead V1 pseudo R prime waves. We should be referring to these P waves in general created by the reentrant tachycardia P prime waves. Only P waves created by the sinus node have the right to be called P waves. P waves originating anywhere else are correctly referred to as P prime waves. Sometimes you may read about these retrograde P prime waves appearing at the onset of the QRS, looking like tiny Q waves. Now, I must say that in almost 40 years of practice, I have never seen one. I asked a couple of cardiology groups I was familiar with if any of them had ever seen a pseudo Q wave during an AVNRT. None could remember ever having seen one. Now, let's get back to our ECG. I can tell you that there are no signs of any retrograde P prime waves on this ECG. What we have is a regular narrow complex tachycardia. This is most likely to be an AVNRT statistically, but there are two other narrow complex tachycardias that could present this way. An orthodromic AV reentrant tachycardia, such as Wolff-Parkinson-White syndrome, or a focal atrial tachycardia. All three tachycardias could look just like this ECG. How can we differentiate between them? Well, if the patient responds to vagal maneuvers or an injection of adenosine, we can rule out atrial tachycardia. It won't respond to either. But that leaves us with AVNRT versus AVRT. If an ECG is recorded while the patient is in sinus rhythm and we see delta waves on the ECG, then we could assume that the tachycardia was due to AVRT. Without a definitive ECG or an electrophysiological study, we can't be sure. But AVNRT is much more common than AVRT. And fortunately, both respond well to the same treatment. Therefore, I would diagnose this ECG as AVNRT and treat the patient appropriately. But what if I'm wrong, and this is really AVRT? Well, I just treated AVRT appropriately. Now let's look at the ECG machine's interpretation. I can't make this point often enough. Never trust the ECG machine's diagnoses without checking the ECG yourself. The first comment on the ECG interpretation is supraventricular tachycardia. That diagnosis doesn't belong here at the top of the ECG. It belongs here. Supraventricular tachycardia, more commonly known as SVT, is a garbage can diagnosis. For instance, what if one of your children were very ill and your pediatrician told you that she had a febrile illness? Okay, but is it a common cold, strep throat, measles, meningitis? They're all febrile illnesses. I personally would like to know which one. Well, we do the same when we use SVT as a diagnosis. Is it sinus tachycardia, atrial tachycardia with 2-to-1 conduction, atrial fibrillation, atrial flutter, junctional tachycardia? Some of these diagnoses are admittedly benign, but others are quite dangerous. What if the patient has an accessory pathway? Atrial fibrillation, atrial flutter, atrial tachycardia, all those tachydysrhythmias could suddenly become imminently fatal. SVT is not a diagnosis. It's not even descriptive. I use the term regular narrow complex tachycardia. Further below now, we see the diagnosis of lateral subendocardial injury. The first problem I have with that is that the machine attempted to diagnose subendocardial injury or ischemia during a tachycardia. ST depression during a tachycardia is not at all unusual, and it does not diagnose subendocardial ischemia. Subendocardial ischemia should be diagnosed only during a normal heart rate. The second thing I take exception with is the fact that the machine diagnosed a possible lateral subendocardial injury. Subendocardial ischemia does not localize. There is no such thing as subendocardial ischemia that is lateral, anterior, inferior, anterolateral, and so on. You cannot localize subendocardial ischemia on an ECG. It's just subendocardial ischemia. Thank you for your kind attention. I'm on LinkedIn and Blue Sky, so visit me there and read my posts. You can also visit me on my own website. I've listed the website address right here. Learn about the master classes that I teach, which are conducted live and in person. I also provide live one-on-one tutoring via Zoom. You can find out more on my website. In addition to teaching, I'm also the author of the Getting Acquainted With books on advanced electrocardiography, available on Amazon and Barnes & Noble. Until next time.